Hello and welcome. My name is Rebecca Rylon-Berry, and I am a psychologist at NYU Langone Health Child Study Center, specializing in the treatment of anxiety disorders, obsessive compulsive disorder, tics, Tourette's disorder, and body-focused repetitive behaviors. Today, I'll be discussing a webinar entitled, What to Do When Your Child's Brain Gets Stuck, Strategies for Reducing Family Accommodation of OCD. You can submit questions at any time today by typing them into the questions pane of the control panel. That's on the right side of your screen. We will answer questions at the end of our presentation. I'll begin with a brief overview of the symptoms of OCD, the prevalence, and the nature and course of the disorder. I'll follow that with a discussion of the gold standard treatment for OCD, which is cognitive behavioral therapy with exposure and response prevention. And then I'll transition into a greater discussion about how families knowingly or unknowingly, many times, engage in the OCD and accommodate the disorder. And then finally, we will cover strategies that you can use and implement every day to help reduce some of the reinforcing behaviors of OCD at home. So OCD, or obsessive compulsive disorder, is a chronic condition characterized by the presence of unwanted and recurrent thoughts, ideas, feelings, or mental images, collectively referred to as obsessions, that drive a person to engage in behaviors or mental acts referred to as compulsions designed to prevent or reduce anxiety. Now, these behaviors and intrusive thoughts can cause substantial distress and inhibit an individual's life areas, including with friends, school, or otherwise being able to participate within everyday acts for the family. OCD occurs not only in adults, but also within children and adolescents as well, and results in significant distress, as well as the functional impairment that I described in the previous slide. We see around 1 to 4% of adults and children who meet diagnostic criteria for this disorder. Childhood OCD itself can be very inhibiting, and it typically has a waxing and waning quality to it, which means that at certain points in time, we may see symptoms being at a peak, and other times they might naturally fade on their own. Otherwise, many times we do know that this condition can last a lifetime, and what we find is that most adult cases of OCD also experienced OCD as a child as well, which calls to a greater need to get treatment early on. So let's talk a little bit about what typical obsessions and compulsions look like. With obsessions, or those intrusive thoughts, we typically see these as being repetitive, persistent, and they can come in the form of thoughts, but also as mental images as well as urges. The individual experiences these things as very unwanted. Sometimes they might even seem silly or uncharacteristic of something that the individual might otherwise think of. The compulsions, or the behaviors that follow the intrusive thoughts, are also repetitive. They're actions that an individual feels driven to perform, and they're done in an effort to neutralize an anxious feeling or distress that the individual is experiencing in their body. Many people endorse that they need to fix the intrusive thought by engaging in some sort of compulsion, and sometimes they have to repeat this behavior until it feels, quote unquote, just right or perfect. Some of the common obsessions and compulsions that we see in children and adolescents include the following. So in terms of obsessions, we typically categorize them by contamination fears, checking, or reassurance. Others have a religious or moral theme to them. And also, just as I mentioned in the previous slide, there is this notion of symmetry and exactness obsessions, wherein an individual feels that they need to do something until it feels just right, or until they do it just right. And common compulsions that we see are hand washing or cleaning, checking of various things like locks, the stove, doors. Also, a type of compulsion is what many parents may see as excessive reassurance seeking or questioning. That's when a child may go to a parent and constantly ask the same question, although sometimes in a different form or said another way, and so that they can get certainty or assurance about some type of event. Current treatment options for pediatric OCD include psychopharmacology, as well as the gold standard treatment for mild to moderate OCD, which is cognitive behavioral therapy with exposure and response prevention. So what does that mean? Well, exposure involves the systematic and gradual confrontation or exposure to feared situations or triggers that an individual has identified within the treatment. So this is very commonly referred to as facing your fears or standing toe-to-toe with fear. But it's important to understand that the process of engaging in exposures is never one wherein we take an individual's worst fear and make them do that thing. Instead, we work, our way up, starting with things that are minimally or mildly challenging, and as an individual gains mastery, we would move up to doing something a bit more challenging. And an important part of this process is wherein the individual really tries, and using a number of skills, to resist engaging in that compulsive or ritualistic behavior that otherwise reinforces the OCD. And through this process of not only facing the fears, but then withstanding the feelings that occur when they don't engage in the ritual, the individual better learns to tolerate distress and discomfort. And then from that, we can see a diminished emotional response to the initial feared trigger or situation. One of the things that we have seen in the literature is that individuals who have OCD that involves the family tend to have more severe cases of the disorder. And that's not in any part due to the family's doing. It's not their fault. It's just that OCD works in many ways to incorporate the family into the rituals. So we commonly see that OCD is associated with overall symptom severity of the disorder and tends to lead to worse outcomes overall. Family members themselves who have individuals in their household suffering from OCD also report significant distress and impairment in their own functioning because of this disorder. We do see that individuals who have family members engage in the treatment, and including parents who learn to become the therapist at home, do have better outcomes. So family accommodation of OCD presents in a number of ways. So this can include specific actions taken by members of the family that can include parents, siblings, other relatives to actually engage in the ritual. Many times OCD will ask, family members to do something for them, or this can also include providing a specific object for the ritual. Other times, family members can give in to the child's OCD demands by helping them to follow a certain routine. And many times, many parents will say that they do this because they want this episode or this sort of emotion dysregulation, this tantrum, to be minimized. So sometimes it's faster and easier to do the thing that the OCD is asking you to do. Other times, parents will get really caught into this trap of answering questions or providing a reassurance to their child about safety, and will answer the same question said in a different form a number of times, and the child will still come back again with the same question maybe a few minutes to a few seconds later. Other times, the accommodations is a little less direct. Parents, because they view their child as having so much distress because of this condition, will thereby take away some of the child's other responsibilities within the home or within school as well. And sometimes this makes sense, and other times what it serves to do is actually reinforce to the child that they can get out of things or avoid things because of these rituals. So we've got to look out for that. So I want us to pause and take a minute to look at one of the questionnaires designed to really highlight whether or not family accommodation of OCD is something that's a little bit bigger than we would like. So this, if we take a look at some of these questions, you can see that it's assessing for reassurance. And one of the things I want you to consider is that, are you doing this on a more excessive level? It's of course natural for children to have questions about almost everything. And I personally believe that, everybody deserves an answer one time. Anything above that to the same question, and if the child gets very upset or distressed when they don't get the answer they need or any answer at all, then that tells us that that might be more of a problem related to the OCD. And again, really think about, are you taking away responsibilities from your child because of this OCD? Are you modifying your schedule a lot, especially in the mornings or with other adaptive routines, in order to accommodate for this OCD, which sometimes many parents report can take half an hour to an hour at the beginning of the day or at the end of the day, and this just becomes taxing for many people involved. To further highlight the cycle of accommodation in OCD, I wanted to present a common example that I see involving reassurance seeking OCD. So many individuals with OCD have fears of foods being unsafe or being otherwise contaminated. So in this example, we have a child who's concerned that the milk was left out on the counter too long, and therefore that temperature increase may have resulted in spoiled or rotten milk. So they think, the intrusive thought from OCD is, this milk is bad. If I drink it, I'll get sick. So they feel anxious or aroused in their body. They feel uncomfortable. And then the ritual involves asking the parent for reassurance about whether or not that milk is safe to drink. So the parent answers saying, sure, of course, milk can somewhat be left out in normal temperatures for some time. The child experiences some physiological relief because they received that answer. But what happens as soon as that parent answers the question and the child associates that with physiological relief, the obsessions continue to come up around food safety. And therefore, the child becomes more inclined to seek reassurance about foods, many more foods, but especially milk, in order to receive that short-term relief. And what happens over time is that the child almost always needs to seek out reassurance from a parent or of another family member before engaging in any food consumption or before engaging in consumption of anything they consider that might harm them. And this can be quite taxing for parents because it can interfere with routines. They might be tired of hearing the same question over and over, and that can lead to conflict between the parent-child dyad. So what can we do about this? So one of the things that we have to know is, as best as we can, understand what OCD looks like, and be aware of when it's coming up, and then come to an agreement, sometimes through a behavioral contract or an open conversation with caregivers and with the child too, because I believe that the child needs to understand how caregivers or other family members are going to respond to their OCD. And everybody should agree to adopt consistent policies for responding to the OCD, even though this is hard. And so one of the main rules that we have, and this is easier said than done, is to not participate in the child's rituals. It can be sneaky. It can feel like your child's asking a harmless question about the safety of milk. But again, if it's coming up over and over again, and if you're seeing your child change their behavior or be distressed about it, then you know that that might be more related to OCD. If you find yourself needing to say a certain word a number of times or say your prayers, 9 times, as I hear some children do at night, then you know that that might be an area where you have to really agree and tell them, I'm sorry, I'm not going to accommodate the OCD. I care about you, and I understand that we're going to have to change some things in order to help you work through this. So setting a boundary on your engagement in the rituals becomes key, although it's not always well received by the OCD because it wants to be continually reinforced. Importantly, one of the primary ways that parents continue to engage with OCD is by answering questions, providing reassurance that the child is okay, or that the distress will go away, or that that quote-unquote bad thing won't happen. And what this reflects is, parents trying to protect and to trying to keep their child from feeling distress. And that is a natural thing as a parent to want to do, and yet within the context of OCD can again be one of the most reinforcing factors. We have to remember that OCD wants absolute certainty in many situations that are fundamentally uncertain, meaning we can't answer whether or not or what will happen in that situation. So because a child is seeking that reassurance, and if they get it from a parent, they have a harder time learning how to be okay or how to deal or cope in an uncertain world. So by actually telling the child, and again, I believe in answering a question one time. I call it my one and done rule. You answer the question one time, and then any other time the child seeks reassurance about these OCD-related things, I tend to like to respond, that sounds like an OCD statement, and I'm sorry, I'm not going to accommodate, sometimes we call it the OCD bully, the worry bully, or just flat out OCD. I'm sorry, I'm not going to give in to the OCD. We made an agreement, and I said I wouldn't do it, so I've got to stick to that. I know it's hard. I know you can use some of your tools that, if you're working with a psychologist like me, you can use. And again, the child won't like it. You may, in fact, see some more distress at the onset, but over time, the child will get used to your responses of not accommodating the OCD, and then they'll hopefully use some other distress tolerance method to deal with not gaining or that reassurance or otherwise doing that ritual. Okay, Importantly, because OCD can often get families to engage in conflict over the rituals, we must remember that OCD is an emotional disorder. It's not based on logic. So sometimes when we try to talk at our kids or reason with them with our what we consider to be logical thinking, the children aren't going to hear you, because OCD is an emotional process whereby the individual feels significant physiological arousal. They feel really awful when faced with these triggers. So they're going to feel and hear that over and above you kind of chastising them or rationalizing with them as to why they shouldn't do this disorder. So what that means when you're sort of confronted with these situations, it's first and foremost important for you to maintain calm as much as you can with your own emotions and try not to talk at the child. Get them in a calm place beforehand and remind them, hey, when you're confronted with this trigger of the warm milk, here's what you're going to do to try and work through that. And I'm also not going to answer that question about its safety. And importantly, it's necessary to make this process of tackling the OCD collaborative rather than harsh and critical. These are very distressing events that can come up, and there's a lot of emotions around it, and yet we need to try and make this as much of a rewarding experience for the child as possible to work through these distressing conditions. Many children, especially younger children, will benefit from the use of a reward system for helping them face their fears. Some old adolescents may take the reward, but they may not. I really like to ask the child or the youth themselves beforehand whether or not they feel like they need that little extra motivation to sweeten the pot for them to try and do these exposure situations. Okay, now OCD can be tricky. It can look like a simple question. Again, some of the things to kind of take a look at throughout your day are times where you're having an emotional reaction to certain behaviors or questions your child is asking, and then see, okay, is there anxiety around that? Is that anxiety disproportionate to what I may see other kids my child's age doing? Is it interfering, meaning is it stopping my child from doing natural activities like, brushing their teeth and then getting their pajamas on and then going to bed? Is there some sort of holdup in the otherwise, typical adaptive routine? And that's when OCD might be going there. If you find yourself, going and doing a lot of extra things for your child, buying a lot of antibacterial soap, always refilling the toilet paper, because sometimes kids wipe a lot when they have a certain type of OCD. You want to make sure that you're sort of seeing that and saying, hey, maybe that's a place where we can actually do some exposure around. Importantly, we must understand that exposures are done not to manipulate, not to make your life miserable, but they're done to relieve anxiety triggered by this disease. Okay, and they're done in the context of trying to eliminate uncertainty around potential threats. Okay, so I like to try and offer, tell parents to have that lens before they go into approaching their child or questioning their child about an OCD behavior. And my absolute number one rule in working with children in this treatment is to remain agnostic. The behaviors and the thoughts that your child is having is not their fault, and it's not your fault. And even though these rituals and this process seems to be taking over your life as well, and especially theirs, we must remember that they are not doing these things intentionally. And I think taking that agnostic approach and actually blaming the disease, blaming the disorder, can help lift off a lot of pressure that especially the child is having in these moments. Okay, so in sum, CBT with ERP is our gold standard treatment that shows a lot of promise in working with youth with mild to moderate OCD. I do want to add that there are instances with youth with higher levels of OCD or more severe OCD that may require an additional pharmacological component. And that has also been shown to be quite effective for some kids in combination with CBT. So we focused a lot on the role of family accommodation, and much of the research shows that in reducing family accommodation, not giving into the rituals, family members can really support their loved ones and help them, decrease symptoms to a greater extent, and also eliminate some of their own distress that they're feeling. Part of reducing accommodation will involve setting limits on these OCD behaviors and routines. And that can be quite difficult to do within the context of staying supportive. So sometimes it can be helpful to have frequent meetings with your child and a professional to discuss what that limit setting will look like, as well as what some of the rewards will be on their end for really facing that fear and tolerating the distress. Okay, and finally, if these symptoms and behaviors feel like they are really causing a lot of conflict and emotional distress for you and your child, it might be important to connect with a professional specializing in CBT with ERP for OCD. Okay. And I've just provided a list of some of the helpful tools for parents that really encompass a lot of the strategies that I've been talking about today. And the International OCD Foundation is a great online resource that has a lot of links for parents about education, just different types of materials to read, but also it provides a list of professionals who are specialized in this treatment. And finally, here's a link for some support groups for parents of youth with OCD. It may or may not be located in your area, but sometimes it's a decent place to start. Okay, so now I'm going to leave some time open for questions. Okay, so the first question is, can a child ever outgrow OCD if treated consistently? Can this be cured completely? That's a great question. So I think you're pointing to the fact that it's necessary. Well, we support the early identification of OCD as one of the things that can really help to offset the severe outcomes of the disorder later on in life. Unfortunately, we don't have any evidence right now that says that OCD can be quote-unquote cured. OCD is known to be a chronic condition, which means that many individuals who experience the disorder early on in childhood, oftentimes do still experience some of the symptoms throughout their life, but with an appropriate course of treatment, and it's important to CBT with ERP, many individuals report better outcomes when they receive that treatment early on in childhood. We often find that adult cases in OCD, about 80% of them experienced OCD in childhood and did not get treatment. They tend to have a more difficult to treat type of OCD and a harder course moving forward. Okay, the second question is, any advice on how to open a conversation when a young child denies that a compulsion is OCD when it clearly is? Yes, this comes up quite frequently. So what I like to advise, and that is, I tell parents, again, we remain agnostic. We're always assuming that this is OCD, but if the child may not buy into it, so I tend to offer to extend an invitation. So I would highlight my observation, hey, Mike, I've noticed that I will do this in a time when they're calm, when I have their full attention, not when they're likely to be engaging in the ritual or when they're doing something else fun or important. They won't talk to me. So I say, hey, Mike, I've noticed that you're spending a lot more time in the bathroom lately, more than you had before. What's up with that? So that's my subtle invitation. And then if Mike responds, well, nothing, it's kind of like I'd like to hang out in there, I say, okay, I'm wondering if that's something that we should bring up with the psychologist so that we can figure out a workaround for it. So I try to engage them in some problem solving while not indeed labeling it as OCD. Sometimes, it's never helpful for us to try and reason with somebody's emotion. So if they're emotional about it, I do let it go, but then I do say, I'm concerned that you are spending a lot of time in the restroom and not enough time on homework, and we're also using a lot of soap. What can we do to try to minimize the amount of time you spend in the restroom? Because other people need to use it too, and we have stuff to do. So again, just remain agnostic and provide a gentle invitation for them to explain, but not sort of like trying to prove that you were right that it's OCD. Try to come up with a workaround anyway. Question 3, is there anything professionals should do differently when symptoms appear on a younger children around 4 or 5 years old? That's a great question. Actually, when we have a young child presenting with OCD that early, almost always the primary treatment is family-based. So a majority of the treatment time will be spent involving the caregivers in the room. Because, a young child to that degree may not have as much insight or ability to remember what this is or to use skills. So we actually rely on parents to be the ones to help facilitate more of the treatment at home. Next question, what type of professional is best to seek out for teens with OCD? Psychologist, social worker, or psychiatrist? Well, oftentimes, all of those professionals can be, very helpful to teens with OCD. What I tend to have parents look for, given that the condition of OCD responds so well to CBT with exposure and response prevention, I'd want to make sure that whatever professional you go to but make sure that they specialize in that particular treatment. Because there's a certain way of doing exposures and approaching and knowledge about OCD that one has to know in order to make sure that we are seeing gains appropriately over time. The next question, if a parent keeps trying to force a child out of his OCD comfort zone, will this break the child free of his OCD or create more anxiety? Excellent question. So, to a certain degree within the exposure and response prevention process, the child has to have some level of insight that this is OCD that's triggering this response, and that they need to confront that fear and that anxiety in order to kind of move ahead and reduce distress over time. I would say that there wouldn't necessarily be more anxiety created because of trying to do an exposure. I think that there will be more tension and more conflict created, which can sometimes, thwart treatment and also cause a rift within the parent-child dynamic, and then a child might just refuse, they might lose motivation or refuse to participate in general. But if exposures are completed gradually, systematically, whereby the child gains mastery over the skills and appropriately in time learns how to tolerate higher and higher levels of distress, usually we will not see an increase in anxiety through that. Unfortunately, sometimes when a child goes from an exposure that might cause them 20% anxiety to then confronting one that causes 80, and without the appropriate skills to tolerate that, then we might see an increase in anxiety about those harder tasks. So we want to make sure that whatever professional you're working with knows how to sort of measure for a child's sense of adequate skill acquisition before moving forward to very, very hard tasks. And what that means, put another way, a child should be able to demonstrate that they can face those lower level exposures and that they eventually become a non-issue before we move up to that harder task. Okay, so this is going to be our last question. What do you do when your child becomes aggressive, when you don't accommodate, and when you try to get him to do exposures? Yes, this is something that we may commonly see, especially if we might push a child to do an exposure that's maybe quite challenging for them. So if there's any aggression, I want to say, okay, let's go back to the drawing board and come up with some sort of plan and family contract for managing aggressive behavior. Just because a child's anxious does not give right or reason to respond aggressively, especially with physical harm, right? So we have to sort of come up with some sort of behavioral contract and reward system for getting a child to utilize tools that would otherwise, make them unable or, less willing to engage in any aggressive acts. And if they're exhibiting aggression, that may be because the task is too hard. Do we need to step down and focus more on gaining skill for exposures that are a bit lower on their hierarchy, get them to feel more confident about those, maybe get them to feel that it's nice to be rewarded for effort, right? It's nice to be rewarded for effort and staying calm at the same time. Okay. All right. So on behalf of the Child Study Center, thank you for joining me today. Once you leave the webinar, you will receive a survey, and we would appreciate if you would complete it. You will receive a follow-up email within a day or two with a link for a recording of today's presentation. And we hope that you can join us for our next webinar with Logging Off, Ways to Stop Bullying by Whitney Woe. That's on Tuesday, October 24th at 1 p.m. Thank you again for your time and for participating. Goodbye.